Good morning, ladies and gentlemen. 早安，大家好。This is Dr. Wei-Chung from Taipei, Taiwan, National Taiwan University Hospital and Children's Hospital. It is my great honor to be invited as a guest speaker on the 8th World Chinese Otolaryngology Head Neck Surgery Conference and the Chinese University of Hong Kong ENT Conference 2022. Hopefully, next meeting, we can meet each other in person rather than online. Today, my topic is ultrasonography of upper airway in children with obstructive sleep apnea. There is no conflict of interest, no financial disclosure in my presentations. As we all know, pediatric sleep disorder breathing, by definition, is a respiratory disorder during sleep with partial or complete upper airway obstruction in children. OSA is defined under the abnormal breathing pattern, completely blocked during sleep, may result in episodic desaturation and repeated apnea. By epidemiology, the prevalence rate is around 1 to 3% in children. Sleep disorder breathing, including a spectrum of upper airway disorders in children, from the normal breathing to primary snoring, mild sleep disorder breathing, then upper airway resistance syndrome, and obstructive sleep apnea syndrome. Although the gold standard for diagnosis of pediatric OSA was overnight polysomnography in sleep lab, however, it is time-consuming with long waiting list and sometimes complicated with so-called first-night effect in some patients. Therefore, in the practical clinical setting, we have OSA 18, the Pediatric OSA Disease-Specific Quality of Life Questionnaire, as the first visit survey in clinics. Further, by ENT local physical examinations, including the grading of tonsillar size and the tongue position, so-called Friedman tongue position. Then the cephalometric X-ray could be used to evaluate the upper airway patency and the size of adenoid tissue. However, as a sleep surgeon, we always eager to know further about how is the upper airway structure looks like before surgical intervention. Therefore, traditional CT scan or combined CT or MRI were utilized as a tool of option to see the more detailed structures for both soft tissue and the bony structures in OSA patients. But in children, this image modality have the disadvantage and the shortcomings. By radiation exposure, need sedation, and cost a lot. Comparing with the other imaging modality to assess the upper airway structures in obstructive sleep apnea, especially in children, ultrasonography benefit for its non-invasive, no radiation exposure, inexpensive, not necessary for sedation, could be performed by real-time examination and get immediately image analysis. Although in adult, it might be limited with the depth of neck structures, but in children, the image resolution could be better and more easy to assess the upper airway under current advanced ultrasound medical technology. And of course, it is cheaper than CT or MRI and could be available anytime in the clinic if you got an ultrasound machine nearby. With these beneficial characteristics, nowadays, the ultrasound has been widely used in otolaryngology head neck surgery, including the head neck tumors and the larynx and the airway evaluations, etc. Several studies did also publish and demonstrated the utility of upper airway evaluation by ultrasound in obstructive sleep apnea. The first report in the literature to use ultrasound for upper airway assessment in OSA patients was published on American Academy of Neurology in 2000. The transducer is fixed at the submental area during sleep with polysomnography recording simultaneously. The posterior and the inferior movement of the pharynx, tongue base, hypopharynx could be visualized and recorded at the same time when the polysomnography demonstrated desaturation during sleep. And the ultrasound event always preceded every apnea event were noted. Again, in 2009, another paper demonstrated that the distance between bilateral lingual artery measured by tongue-based ultrasound could positively predict the severity of obstructive sleep apnea, but also in adults. This study from Taiwan, chest physician Professor Wang and his group also used segmental view of the ultrasound to measure the width of the retropalatal area in OSA adult patients. They found that in adults with severe OSA, demonstrated shorter hyperechoic gas line at the retropalatal area under the Muller's maneuver, which could be one of the OSA prediction parameters when combined with the neck circumference measurement. Another research group from Taiwan, Dr. Chen and his team, published seriously papers regarding the measurement of tongue-based ultrasonography parameters, including dynamic changes of the thickness and the elasticity of the tongue base and the pharyngeal wall. This study indicated that in adults, the tongue base thickness and the consistency were important factors for the severity of adulthood obstructive sleep apnea under ultrasound measurement. Except the tongue base evaluation by ultrasound, there is another research group focusing on the lateral pharyngeal wall measurement in obstructive sleep apnea. This study used an ultrasound curve probe to measure the lateral pharyngeal wall complex thickness, and they found that in adults, the thickness of the lateral pharyngeal wall complex measured by ultrasound were associated with the severity of obstructive sleep apnea with fair correlation with the head neck MRI findings. Regarding the reliabilities of ultrasound measurement in upper airway structures, comparing with other traditional image devices, here comes the challenge question that whether the upper airway structure measured by ultrasonography were reliable and comparable with CT or MRI. From these two studies and others, it seems that there was no significant difference between ultrasound measurement, either compared with CT or MRI in head and neck structures, and the airway with fair correlation to each other. In summary, under the current improvement of high-resolution ultrasonography technology, it could provide a non-invasive image evaluation modality which could be utilized on upper airway to detect the multi-level obstruction from venom, retropalatal, oropharynx, tongue base, retroglossal, hypopharynx, even lower to larynx, vocal fold, and the subglottis, including the soft tissue, cartilage, airway space, and the vessels located over the upper airway in OSA adults, and some of the major parameters were correlated with obstructive sleep apnea severity. As you can see, most of the above papers are focusing on adult OSA, rarely on children, and we all know that the pathophysiology of OSA in children is different from adults. Therefore, we try to investigate the upper airway structure in children with obstructive sleep apnea by ultrasound and also try to figure out is there any changes after adenotonsillectomy. Therefore, we designed a prospective study to investigate the applicability of ultrasound in children with sleep disorder breathing and the obstructive sleep apnea. The aims of our study including whether the ultrasound technology could be used as one of the image tools for assessing sleep apnea in children, and which ultrasonic image parameters could correlate to the severity of OSA in children. The evaluation of upper airway architecture by ultrasonography in sleep disorder breathing children technically are quite similar to adult, just need more patience and sometimes need the family to assist and let the child calm down and feel comfortable. You can apply right or left oblique transverse view, submental view, right and left oblique sagittal view, and even sometimes just in case, when a child falling asleep spontaneously, you will be able to see the dynamic upper airway changes of sleep sonography. As for the parameters from ultrasound measurement, including tonsillar diameters, estimated tonsillar volume, intralumen protruding percentage, intertonsillar space, tongue volume, width and depth, lateral pharyngeal wall thickness, and also the dynamic shifting of the above structures under Muller's maneuver, etc. Submental view below the mandible can be used to evaluate the dynamic oropharyngeal airway, which is the most crucial anatomy for sleep disorder breathing and obstructive sleep apnea in children. Occasionally, in some cases, when a child just falls asleep during our ultrasound examination process, compared with the sleep endoscope, the DICE could be mimic the natural sleep status of children, which we named it as the sleep ultrasonography. Also, by submental view, you can estimate the hypertrophy grading of the tonsil and see the intertonsillar airway space, which image looks very much similar to the ENT local findings of our oral cavity and the oropharynx. We also use the ultrasound linear transducer to measure the tonsils in three-dimensional aspect by transverse and the longitudinal scan. The lateral dimension of tonsil to neck thickness ratio were calculated too. Then the estimated tonsillar volume could be calculated as one of the outcomes for further analysis in our study. By oblique sagittal view in ultrasound image, you can easily identify the anatomy level above supraglottis and below the lower pole of the tonsil. That is so-called the lateral pharyngeal muscular complex. As for measurement of the lateral pharyngeal wall complex, we use the curve transducer with 6 MHz to detect the thickness of lateral pharyngeal wall complex at retropalatal level by longitudinal view. The hyperechoic line is the lumen surface of the pharynx. Between the mucosal line and the internal carotid artery, is where the lateral pharyngeal wall complex is located. The lateral pharyngeal wall complex thickness was measured in both resting status and under the Muller's maneuver, which could mimic the dynamic changes during sleep status of children. The video demonstrated the dynamic changes of lateral pharyngeal wall complex under Muller's maneuver. We found that both of the lateral pharyngeal wall and the total parapharyngeal neck thickness will be thicker under the Muller's maneuver by ultrasonic measurement. Our initial paper was published in JAMA Otolaryngology Head Neck Surgery in 2018, which all the ultrasound were performed by well-trained pediatric otolaryngologists. Totally, 82 children with sleep disorder breathing were included, which including 20 primary snoring with apnea-hypopnea index less than 1 per hour, and the 62 obstructive sleep apnea children with apnea-hypopnea index more than 1 per hour. Mean age was about 8 years old, and 75% were boys. This table demonstrated parameters measured by ultrasonography at the tonsillar level, including the tonsillar length, width, and height, and volume. We found that the tonsillar dimension, volume, and the tonsil to neck ratio had no association with obstructive sleep apnea severity and the apnea-hypopnea index. This table shows the ultrasonography parameters at retropalatal level. We found that the lateral pharyngeal wall complex was thicker in OSA children than in primary snoring children. The total neck thickness at the retropalatal level was also thicker in OSA children than in primary snoring children. The results show that the lateral pharyngeal wall thickness, both in resting and the Muller's status, had correlated with apnea-hypopnea index, which means that the lateral pharyngeal wall was much more easy to collapse in OSA children than in those without OSA. Furthermore, after adjust with age, gender, and ratio, body mass index, we found that the lateral pharyngeal wall thickness was an independent predictor of childhood obstructive sleep apnea. In summary, our first study showed that the lateral pharyngeal wall was thicker in children with OSA than those with primary snoring, which indicate that the lateral pharyngeal wall thickness could be an independent predictor of OSA in children. However, the tonsillar volume estimated by ultrasound measurement was not associated with apnea-hypopnea index and the OSA severity in children. The relationship between tonsillar grade and the OSA in children is still controversial and under debate. We all know that not all children with hypertrophic tonsil will result in OSA. According to previously published systemic review, show that the subjective size of the tonsil is not so strongly correlated with apnea-hypopnea index. Our study also demonstrated that there is no difference in estimated tonsillar size or volume between OSA and the non-OSA children. As the role of lateral pharyngeal wall thickness in OSA, some studies show that lateral pharyngeal wall is thicker in male adult OSA patients, but not yet being reported for children. Our research was the first one published paper to show that there is also an increase in lateral pharyngeal wall thickness in children with obstructive sleep apnea. especially under the Muller's maneuver to induce upper airway collapse in supine position. Besides, there is an increasing for the parapharyngeal neck thickness in OSA children too. Furthermore, we also perform the 3-month follow-up ultrasound measurement in OSA children after receiving adenoid tonsillectomy. This table demonstrated that the result. It shows post-adenoid tonsillectomy, the lateral pharyngeal wall thickness significantly decreased under Muller's maneuver. However, the lateral pharyngeal wall change was only significant in children without residual OSA. No ultrasonography parameters of the upper airway structures could independently predict the surgical outcome in children with residual obstructive sleep apnea. Which result means that after adenoid tonsillectomy, the total neck thickness at tonsillar level is decreasing, correlating with the increasing of the oropharyngeal airway space after surgery. There is also no change in resting lateral pharyngeal wall and the parapharyngeal neck thickness in all children, but decreasing in the changes of lateral pharyngeal wall during the Muller's maneuver only show in OSA children. This finding indicates that the collapsibility of the lateral pharyngeal wall and the parapharyngeal upper airway structure decrease after surgery. This might mean that the adenoid tonsillectomy will make the lateral pharyngeal wall or parapharyngeal complex remodeling, which result from tissue fibrosis or some elasticity changes after the surgery. There is still some limitation in the application of ultrasound in upper airway structure during sleep. The ultrasound is very much operator dependent and needs some training. The airway volume inside the lumen was very difficult to delicately evaluate. Also, the head-neck position might not be exactly as the sleep status. And sometimes some of the children will not be able to fully cooperate during the examinations. However, this is a non-invasive tool which could provide a new technique in further sleep research. In conclusion, ENT head-neck ultrasound is one of the useful diagnostic tools to evaluate upper airway soft tissue outside the lumen in children. In children with sleep disorder breathing or obstructive sleep apnea, by ultrasonic measurement, although the estimated quantified tonsillar size had no correlation with obstructive sleep apnea, but the lateral pharyngeal wall complex had an important role in children with obstructive sleep apnea. Compared with sleep endoscopy on upper airway evaluations, ultrasound can show the collapse outside the airway lumen of extraluminal component in the upper airway structures. However, the sleep endoscope show better inside the airway lumen. The intralumen airway patency. Upper airway did have a very complex anatomy versus respiratory physiology, especially during sleep. We need to know the intralumen airway space and the extralumen structures, both the soft tissue and the bony architectures. Therefore, by utilizing multiple image modality combined together, we should be able to comprehensively evaluate the patient before treatment and get into a holistic care to each patient by precision medicine. Thank you very much again for the kind invitation and all of your attention. Hopefully, we can overcome the pandemic and meet each other in person very soon. No matter where you are, please stay safe. Here is my email, and I will be very happy to answer any question.